Good afternoon. So I'm going to give a quick background on the field of autologous and allogeneic hematopoietic stem cell transplantation, go over sort of the state of the art, and then the two-thirds of the talk afterwards will focus on complications associated with stem cell transplantation. So just to go over some terminology, there's two types of hematopoietic stem cell transplants. There's autologous hematopoietic stem cell transplants. These transplants involve collecting either bone marrow or peripheral blood stem cells from the patient and then cryopreserving them, then treating the patient usually with cancer, with high-dose chemotherapy and with radiation to try to eradicate as much of the malignancy as possible. That results in also eradication of the hematopoietic system. These stem cells are then thawed and then infused into the patient intravenously to reconstitute hematopoietic function. Autologous transplants represent first-line therapy for patients with multiple myeloma. They've been shown in a number of randomized trials to improve progression-free survival and improve overall survival. Autotransplants are also used as second-line therapy in patients with either relapsed Hodgkin's disease, largely intermediate or high-grade lymphomas, as well as patients with relapsed non-Hodgkin's lymphoma. They prolong survival in relapsed non-Hodgkin's lymphoma, and they prolong disease-free survival, but not survival in relapsed Hodgkin's disease. Autotransplants are much safer than they were 15 or 20 years ago. The risk of mortality from an autotransplant in most centers is quoted at less than 5%, with most centers having mortality rates in the range of 1 or 2%. And when you look at why patients die after an autotransplant, the major reason is because of relapse of the underlying malignancy, with transplant-related complications occurring less commonly, infection being one of the leading causes of mortality after autotransplants. Allogeneic stem cell transplants, on the other hand, use hematopoietic stem cells from either a tissue-matched, HLA-compatible relative or increasingly unrelated donors, and more recently, cord blood as a source of stem cells. Patients get conditioning, and in this case, have the stem cell source either infused fresh or thawed and infused in the patient with the malignancy. I'm going to focus in this talk mostly on complications related to allogeneic transplantation. Allotransplants are an increasingly used procedure over the past 10 to 15 years. There's about 20,000 allotransplants performed annually, and the number of transplants is increasing recently due to, one, an increasing probability of being able to find an HLA-compatible donor, and that has to do with the unrelated registry growing significantly from 4 or 5 million about 10 years ago to now more than 15 million healthy donors worldwide. There's also been an increasing use of reduced intensity conditioning transplants, otherwise known as mini transplants or non-myeloablative transplants for patients that have either medical comorbidity or are older, where mortality with a fully ablative transplant would be prohibitive, and that's now allowed us to expand the application of this procedure to patients over the age of 55 up to a cutoff of about 75. So how do allotransplants cure patients with malignancy? This represents a patient with cancer. Patients receive a conditioning regimen that's designed to do two things. One, to try to reduce the malignancy as much as possible. Secondly, it immunosuppresses the patient to prevent rejection of the allograft. The patient then receives an infusion of hematopoietic progenitor cells, and in most cases also receives lymphoid tissue with the transplanted graft. That includes T cells, B cells, and natural killer cells. And we know that T cells in particular transplanted after the transplant are able to mop up minimal residual disease and potentially render the patient disease-free. We call this immune effect that occurs, the graft versus leukemia or the graft versus tumor effect. It often occurs in the context of graft versus host disease, and it in and of itself can be curative. The two types of allogeneic transplants, as I said before, are conventional myeloablative conditioning. This involves usually high doses of alkylator chemotherapy or total body irradiation, and then reduced intensity transplants that use sub-ablative doses of chemotherapy or radiation, where you don't wipe out the hematopoietic system of the recipient, where they can have autologous hematopoietic recovery, and you get a state of mixed chimerism where the hematopoietic cells are being contributed by the transplanted stem cells from the donor as well as from the recipient, And ultimately, the donor T cells that are transplanted will eradicate the recipient's hematopoietic cells, and the patient will become a full donor chimera. If we look at transplant numbers, roughly 20 to 25% of all transplants performed use reduced intensity conditioning. That number has increased over the last 10 years, but seems to have plateaued now. So still about 75% of patients getting transplanted will receive the conventional fully myeloablative transplant. And this is just looking at patient age and time periods, and you can see that between 1987 and 1993, only a minority of patients that were transplanted were over the age of 50, and that was because a number of studies had shown really, really high mortality rates in patients that were older. With the advent of reduced intensity transplants and also with better knowledge of ways to give ablative chemotherapy and radiation safely, you can see that there's been a shift towards an increasing number of older patients being transplanted, now with patients over the age of 50 representing about 25% of all the patients that go through the procedure. So for patients that have an HLA identical sibling, that's the transplant of choice. That's only about 25% of patients that have a malignancy that could be potentially cured with the transplant. So that still leaves about 75% without a donor. As I said before, the unrelated registry has grown now to 15 million unrelated donors. For a Caucasian in the United States, there's about a 60 to 70% chance that you'll find a perfectly matched HLA-compatible donor. For an African American, that number is smaller, in the range of 45%, and that has to do with more genetic diversity among HLA molecules in that population. And this is looking at transplant numbers, and the yellow bars here, these are overall transplants. In yellow, it's the number of patients receiving unrelated donor transplants. So you can see that there's been an increase in that number, and it's anticipated within the next 5 to 10 years there will be a greater number of unrelated transplants being performed than fully matched sibling transplants. The good news is that there's been an improvement in the safety of unrelated transplants. 15 years ago, there was a clear mortality disadvantage to receiving an unrelated transplant compared to a transplant from an HLA identical sibling. That mortality increase in unrelated donors was related predominantly to an increase in the risk of graft versus host disease. Now with the advent of high-resolution molecular typing of HLA molecules, you can see that survival rates are very comparable among recipients of a matched sibling versus an unrelated donor transplant. So for the 25% or so patients that don't have either a sibling donor or an unrelated donor, another source of stem cells that are becoming more popularly being used in the last 5 years or so are umbilical cord bloods. Umbilical cord blood is collected at the time of delivery from the placenta into a bag. It undergoes red blood cell starch sedimentation and then is transferred to a very small bag, usually about 25 mLs, and then is cryopreserved. Umbilical cord blood is a very rich source of hematopoietic stem cells. And the T cell population contained within these grafts are also naive and are less likely to cause graft versus host disease. So the good news with these transplants is that you don't have to have a perfectly matched transplant to have an adequate transplant outcome. Most cord transplants are mismatched, either 1 or 2 HLA loci. We usually type for 6 loci, and most transplants are either a 1 mismatch or 2 out of 6 mismatch. And remarkably, there's less graft versus host disease associated with HLA mismatching with cord blood transplants, probably because these T cells are naive. This is some registry data from the Bone Marrow Transplant Consortium showing survival in patients with hematologic malignancies receiving a transplant from a fully matched unrelated donor versus a mismatched cord blood recipient. And you can see that cord blood survival is inferior, although you still are able to salvage about 35% or 40% of patients that otherwise would have almost certainly died from their underlying malignancy. The number of unrelated transplants and cord blood transplants are increasing. The cord blood registry now, public inventory, has worldwide an estimated 450 to 500,000 units in it. The bad news with cord blood transplants are they are very much in their infancy. Because of the low stem cell number, the time period until neutropenia resolves is protracted. It can be anywhere from 22 to about 30 days until these cells engraft and neutropenia resolves, and patients are at risk for opportunistic infection during that time period, and that is associated with a very high risk of early transplant-related mortality. This is data on 514 patients published this year. This is registry data that reports a 44% mortality rate by day 100 and a 63% mortality rate by 6 months post-transplant. And then you see it plateaus off. So many of these deaths that are occurring early on are related to opportunistic infection associated with either protracted neutropenia as well as the fact that you're transplanting naive T cells and there are problems with viral reactivation and death from viruses. So clearly work that needs to be done, but the hope that these transplants will be safer in the future. This is just looking at the probability of survival in patients receiving a matched sibling transplant versus an unrelated donor transplant, and you can see that survival over the past couple of decades has been slowly improving for a number of reasons: better supportive care, better knowledge of how to condition patients without causing morbidity, and better HLA typing. So we'll focus now on morbidity associated with hematopoietic stem cell transplantation. If you look at the causes of death after a transplant, you can see that in contrast to autologous transplant, where the biggest piece of the pie is from relapse, in allotransplants, the majority of death is related to transplant-related mortality. If we break up the contributors to transplant-related mortality, infection and graft versus host disease are the two biggest contributors, followed by organ toxicity, which may be related to the conditioning regimen, things like pneumonitis or veno-occlusive disease or idiopathic pneumonia syndrome, which we'll discuss in more detail in a moment. So Dr. Basur had asked me to have a slide to discuss some of the complications associated with the medications that we commonly use with stem cell transplantation. For graft versus host disease prophylaxis, most transplants will use a calcineurin inhibitor that's T-cell immunosuppressive, such as cyclosporin, CSA, or tacrolimus, otherwise known as FK506. These drugs cause dose-dependent renal insufficiency. They cause hypertension in almost 100% of patients that are on these drugs. They cause hypomagnesemia. Hypertension that's poorly controlled can lead to posterior reversible encephalopathy syndrome, which can present commonly with seizures. They also can cause gingival hyperplasia. And again, most of these toxicities are dose-dependent. Pneumocystis prophylaxis is used in almost all patients going through the procedure. Bactrim is the most commonly used drug, and that drug is associated with marrow suppression. For CMV reactivation, and we'll go through CMV reactivation a little later, the two most commonly used drugs are either ganciclovir or its oral equivalent valganciclovir or foscarnet. Ganciclovir, valganciclovir cause marrow suppression, with neutropenia being the most common manifestation of long-term use of these drugs. Foscarnet can cause renal insufficiency and electrolyte abnormalities. So our decision as to whether or not to use ganciclovir or foscarnet in patients that have CMV disease or CMV reactivation is often guided by whether or not their marrow reserve is good. If they have neutropenia, we would be more inclined to use foscarnet. If they have renal insufficiency and good blood counts, we would be more inclined to use ganciclovir. GVHD treatment consists of a number of different immunosuppressive drugs, such as corticosteroids, cyclosporin, sirolimus, targeted antibody therapies such as daclizumab or infliximab. All these drugs knock down the immune system, and they can increase the risk of opportunistic infection. Steroids in particular increase the risk of bacterial and fungal infections, and the drugs that are more T-cell specific increase the risk of viral infection and pneumocystis. This is an example of a patient that's on cyclosporin that's developed gingival hyperplasia. So if we look at post-transplant complications, we can break them up into infectious and non-infectious. Among the infectious complications, there is conditioning, associated opportunistic infection. So this is occurring usually during the neutropenic phase when the patient has just received the conditioning regimen and has a period of about 10 to 14 days after a peripheral blood stem cell transplant, or 22 to 30 days after a cord blood transplant where neutropenia occurs. And at this time point, invasive fungal infections commonly occur, as well as opportunistic bacterial infections. Following neutrophil recovery, patients have a period of time where they are susceptible to infections that are associated with compromise of cellular immunity. This occurs because the T-cell repertoire is not expanded from either naive or memory populations to recognize viral reactivation, as well as the fact that patients remain on cyclosporin, usually full dose, for at least 100 days after the transplant and don't begin cyclosporin tapering, in some cases to 6 months to a year after the transplant. Viral infections occur commonly during this window of compromised cellular function. CMV infection occurs from reactivation within the recipient. The window of risk for CMV reactivation is usually from engraftment to about 100 days post-transplant, and we monitor with weekly PCRs for CMV reactivation so that we can initiate preemptive therapy, and we'll talk more about that in a bit. There's also a risk during this time period for other nasty viruses such as respiratory syncytial virus, which in the context of an allogeneic transplant, when it causes pneumonia, is associated with a very, very high mortality in the range of 50 to 75%. Pneumocystis pneumonia can occur from the time of engraftment, usually to about 6 months or a year post-transplant until lymphopenia resolves. Patients that remain on cyclosporin continue on pneumocystis prophylaxis. And then patients that develop chronic graft-versus-host disease also have compromised immunity and are at risk for fungal infections, viral infections such as zoster, and encapsulated bacteria such as pneumococcus, and patients will typically be placed on penicillin prophylaxis. So the risk factors for invasive fungal infection are related to anything that causes a delay in neutrophil recovery. So that would be things like transplanting a low number of stem cells using a cord blood transplant. Anyone that has acute or chronic graft-versus-host disease is commonly treated with steroids, and that can compromise neutrophil function and lead to an increased risk of opportunistic fungal infection. And then any secondary neutropenia that can occur after transplant, such as patients that have CMV reactivation being treated with ganciclovir that may develop a secondary neutropenia, would be at risk for invasive fungal infection. Patients that have acute or chronic graft-versus-host disease are particularly high risk for invasive fungal infections. There's clear-cut evidence now that prophylactic fungal therapy in this cohort can prevent death from invasive fungal infection. This was a study that was published in New England Journal of Medicine a couple of years ago that randomized patients with either acute or chronic graft-versus-host disease to receive azole therapy with either fluconazole or a more broad-spectrum azole posaconazole, which covers aspergillus and mucor. Patients in this study, there were 600 patients in this study, and the outcome basically showed that survival was similar, but death from invasive fungal infection was significantly lower in the recipients of posaconazole. And this now represents a standard prophylactic agent in the context of this complication. So CMV reactivation occurs commonly after allogeneic stem cell transplants. It can affect anywhere from 30 to about 75% of transplant recipients. It's defined as detection of CMV in the blood, usually by PCR without evidence for CMV disease. In contrast, CMV disease is organ-specific disease that occurs as a consequence of CMV reactivation. It usually involves either the liver presenting as hepatitis, the gastrointestinal tract, where it will present as either gastroenteritis or colitis with diarrhea, or it can involve the lungs, and CMV pneumonitis is something that's really a dreaded complication of allotransplant because the mortality rate is quite high, 50% or higher once CMV is in the lungs. One thing that's important to keep in mind is that CMV reactivation only occurs in transplant recipients that are at risk, and we define risk being those patients that come into the transplant that have serologic evidence for prior CMV infection, or that are receiving a transplant from a donor that has serologic evidence for prior CMV infection. Those that are not at risk would be if the patient and the donor are both serologically negative for CMV pre-transplant. With the use of CMV negative blood products, you don't see CMV reactivation or disease in that cohort, and that would roughly be about 20% of transplant recipients would fall into that category of no risk. CMV reactivation, as I said before, usually occurs at the time of engraftment, day 14, or earlier to about 100 days post-transplant, and the risk of CMV reactivation is directly related to the degree of compromise in cellular immunity in the recipient. So patients that get a transplant that's T-cell depleted to try to prevent graft versus host disease, that's quite effective in preventing graft versus host disease, but it also leads to an increase in opportunistic viral infections, including CMV. Patients that have acute GVHD are high risk for CMV reactivation, and patients that are serologically seropositive for CMV, having had prior CMV infection, that receive a transplant from a seronegative donor are at increased risk for CMV reactivation. And that's because, as I said before, we transplant immune cells from the donor. If the donor has never been exposed to CMV, in this kind of a scenario, CMV will reactivate in the recipient, and the immune system from the donor will be naive to CMV. So in order for the donor to mount an effective immune response, that will be delayed, may take several weeks, and that could lead to recurrent episodes of CMV reactivation. So if we have a choice between two donors that are HLA identical, and we're doing a transplant in a patient that's CMV seropositive, we'll actually choose the donor that's CMV seropositive over the donor that's CMV seronegative so that we can transplant that viral immunity. One thing that's important to keep in mind is that the PCRs usually turn positive 2 to 3 weeks before patients will develop CMV disease, and that's important because preemptive therapy with foscarnet or ganciclovir is highly effective in clearing CMV reactivation, almost 100% effective. So you do have a couple of weeks lead time from the time that CMV reactivation occurs till disease occurs. This is a study looking at the cumulative incidence of CMV reactivation based on the serologic status for CMV in the patient and the donor, and this is showing that most of those reactivations are occurring between day 30 and 80 up to about 100 days post-transplant, with the highest risk for CMV reactivation being in recipients that are positive and using a donor that's CMV seronegative. And you can see if you have a recipient that's negative, regardless of the donor status, the risk of CMV reactivation is very low. Okay, so as Dr. Massour said, the questions are embedded in the talk, so this is the first question, and I'll read through it before you answer it. A 43-year-old male with aplastic anemia received an allogeneic peripheral blood stem cell transplant. Pre-transplant, the patient was CMV antibody positive, and the donor was CMV antibody negative. On day 24, the patient developed a new right lower lobe infiltrate and bronchoscopy. BAL subsequently grew out stenotrophomonas resistant to all antibiotics except Bactrim. The patient is treated with high-dose Bactrim associated with resolution of the pneumonia, but remains neutropenic with Bactrim therapy. 7 days after GCSF is started, his ANC goes from 100 to only 200 cells per microliter. A routine screening CMV study returns positive with 2,500 copies of CMV. The patient over the past 24 hours notes low-grade fevers. Besides an ANC of 200 cells, his blood tests are unremarkable. The patient should A, continue GCSF and have a repeat CMV performed in a week. B, start empiric ganciclovir therapy. C, start empiric foscarnet therapy. D, start empiric cidofovir. E, undergo a chest CT scan to rule out CMV pneumonitis. If positive, begin CMV therapy. F, start empiric ganciclovir therapy and IVIG. Can we start the timer? Okay. So we'll go through the responses. The two most popular responses were number 2 or number 3, either ganciclovir or foscarnet. So the first answer is incorrect. Continued GCSF and have a repeat CMV PCR performed in 1 week. The patient has a very high CMV copy number, has clearly reactivated CMV, and if you wait a week, you shorten that time period from reactivation to actual disease. So this is somebody that you would want to treat. The treatment options that are given are ganciclovir, foscarnet, cidofovir. Cidofovir is incorrect. This drug has some activity against CMV, but is certainly not considered a first-line agent at this time, so that would limit your treatment choice between ganciclovir and foscarnet. The answer is C, foscarnet. The reason is because the patient has neutropenia associated with Bactrim use, and despite getting GCSF, remains neutropenic. So this would be a person where you have 2 drugs that are highly effective in treating reactivation of CMV. Ganciclovir would cause more marrow suppression and would increase the risk of this patient developing a serious opportunistic infection from neutropenia. So that would make foscarnet the desired therapy. You wouldn't wait for a CT scan to show CMV pneumonitis because by that time the cat's out of the bag and mortality would be very, very high. And again, ganciclovir is not the drug of choice because of neutropenia. Dr. Massoud asked me to address what would go into the decision between using IV ganciclovir versus valganciclovir in the event that we were going to use ganciclovir. Basically, most of the studies that are out there suggest equivalence between these drugs in terms of their ability to clear CMV. The one caveat would be that a number of patients that reactivate CMV also have gastrointestinal graft versus host disease, and these patients can have significant problems with absorption of medications. So in that case, we would tend to avoid oral medications, and we would use IV drugs as the preferred route of therapy. So we'll move now to post-transplant non-infectious complications. There are a number of conditioning-associated complications that can occur. High-dose alkylator therapy and high-dose total body irradiation can cause liver toxicity, veno-occlusive disease, otherwise known as sinusoidal obstructive syndrome. That usually occurs within the first 21 days of the transplant, and we'll go through that disease in more detail in a minute. Pulmonary complications that can occur acutely include pulmonary engraftment syndrome that occurs at the time of neutrophil recovery within 96 hours, and then thereafter to about 120 days post-transplant idiopathic pneumonia syndrome. Acute GVHD, the risk is from the time of engraftment to 100 days post-transplant by definition. Chronic graft versus host disease, by definition, the risk is from day 100 to about 2 years post-transplant. If you don't develop chronic GVHD by 2 years post-transplant, you won't develop it. And then disease relapse, the greatest risk is within the first couple of years of the transplant. If patients remain disease-free with acute leukemias, usually by 3 years, that risk of relapse becomes very, very low. So veno-occlusive disease or sinusoidal obstructive syndrome is a clinical syndrome associated with conditioning that presents with a triad of symptoms: painful hepatomegaly, elevated bilirubin associated with jaundice, and fluid overload, which presents typically as ascites and peripheral edema. The onset is usually within 3 weeks of the conditioning regimen. The incidence about 15 years ago was quoted to be about 30 to 40%. That incidence has declined dramatically since over the last 15 years, largely because there's been knowledge of what causes this process. There's been de-intensification of the conditioning regimen, and there's also been a movement away from the use of oral busulfan, now being substituted with IV busulfan, which has much more predictable pharmacokinetics. Clinically, this syndrome resembles Budd-Chiari syndrome, so patients look like they have portal hypertension, and the pathophysiology is associated with these conditioning agents causing direct injury to the hepatic venous endothelium and the sinusoidal endothelial cells, as well as the hepatocytes, and that triggers a coagulation cascade that leads to progressive occlusion of hepatic venules. The diagnosis is primarily a clinical diagnosis. That's very important to keep in mind. We don't have any magic tests that can make this diagnosis. If patients don't have the triad of symptoms, then most likely they don't have veno-occlusive disease. The one blood test that's commonly used to confirm this diagnosis is measurement of plasminogen activator inhibitor levels, which are decreased, and this is nearly 100% sensitive for patients that have this process, but importantly, it has a very, very low specificity. There's a number of other conditions that can lower plasminogen activator levels, such as infection and graft versus host disease. So it's a sensitive test, but not a very specific test. Patients with VOD are managed predominantly with supportive care. This includes measures to try to optimize their fluid status. Patients can develop hepatorenal syndrome. If they go into renal failure, these patients are often managed with CVVHD. In terms of actual therapeutics to treat VOD, there's really no established therapy for this condition besides supportive care. Thrombolytic therapy and anticoagulants such as TPA and heparin should be avoided, particularly in patients that have multi-organ failure, as a number of studies have shown these drugs really don't improve survival and are clearly associated with an increased risk of serious and sometimes fatal bleeding. Difibrotide is the new kid on the block in terms of therapeutics. It's a single-stranded oligonucleotide that has antithrombotic and fibrinolytic properties, and is known to have effects on the microvascular endothelium. There have been a number of phase 2 studies, including a randomized phase 2 study, that have used this agent in patients that have severe veno-occlusive disease that meet criteria for having a very high risk of mortality, that have shown complete remission rates in the range of 30 to 60% with this drug compared to historical controls that would have had complete response rates and survival of less than 10%. So I think this drug now is in phase 3 study, but still remains investigational for treating VOD. The other approach can be to try to decrease portal pressures by doing maneuvers such as TIPS procedures, although that's never been shown to prolong survival. And in patients that have severe veno-occlusive disease, that have single organ failure, liver transplantation is something that can also be considered. Okay, so we'll move on to the next question. This patient is a 43-year-old male with CLL. It's refractory to therapy with fludarabine, undergoes a reduced intensity allogeneic transplant using cyclophosphamide and fludarabine from an HLA identical sibling. Both the patient and the donor are CMV seronegative, so that should tell you something. The patient develops nausea and vomiting associated with a conditioning regimen requiring TPN for 2 weeks. On post-transplant day 8, while still neutropenic, the patient develops gram-negative bacteremia with Klebsiella, which responds to treatment with ceftazidime. Neutrophil recovery occurs on day 13. On day 14, his total bilirubin is 3.4. Direct bilirubin is 2.9 with an alkaline phosphatase normal at 133. Cyclosporin level is therapeutic at 340. Physical exam is otherwise normal without ascites or hepatomegaly. Liver transaminases are normal. Chimerism study shows graft rejection with autologous hematopoietic recovery. So this can occur in about 10% of patients that get a reduced intensity transplant. They reject the transplant and their own counts come back. A Pi-1 level returns markedly elevated at 1,000 micrograms per deciliter. The most likely etiology of the hyperbilirubinemia is A, acute liver GVHD, B, CMV hepatitis, C, multifactorial, drug-related cyclosporin, TPN, and being NPO, or D, veno-occlusive disease of the liver. And you can start the timer. Okay, so looks like C and D were the most popular responses. The answer is C. A, acute liver GVHD. The reason the patient doesn't have liver GVHD is because rejection of the graft has occurred, and in order to get GVHD, you have to have immune cells from the donor and graft. B is incorrect, CMV hepatitis. The patient doesn't have a hepatitic picture. The transaminases are normal, and the patient is not at risk for CMV. Both the patient and the donor are CMV seronegative. Veno-occlusive disease of the liver is incorrect. A couple of things that would tip you off to that. First of all, It occurs very rarely. Second of all, the conditioning regimen is using reduced intensity conditioning. And as I said before, this complication is related to high-dose therapy. And most importantly, the patient doesn't have the triad of symptoms that occur with VOD, so you don't see hepatomegaly and you don't see ascites, so that basically rules VOD out. Multifactorial is correct. We very often see mild elevations in bilirubins occurring as a consequence of drugs in patients being on agents such as cyclosporin, narcotics, and being on TPN. Okay, so we will now move to pulmonary dysfunction after stem cell transplantation. Shown here are a number of complications that can occur that include bronchiolitis obliterans, or that's called BO or BOS, BOOP, bronchiolitis obliterans organizing pneumonia, which is renamed COP now, cryptogenic organizing pneumonia, PERDS, which is peri-engraftment respiratory distress syndrome, also known as pulmonary engraftment syndrome, idiopathic pneumonia syndrome, and diffuse alveolar hemorrhage. We'll go through each of these. So pulmonary engraftment syndrome is defined as a syndrome that occurs within 96 hours of neutrophil recovery, and that's defined as a neutrophil count being 500 or greater. It presents as fever, rash, and dyspnea associated with hypoxia and non-infectious pulmonary infiltrates. The diagnosis is basically a diagnosis of exclusion. Patients need to undergo a bronchoscopy to rule out an infectious origin, an echocardiogram to rule out heart failure. And the differential is other processes that include diffuse alveolar hemorrhage, which we'll talk about in a minute. The etiology of this syndrome is thought to be related to release of agents such as elastase, which cause damage to vascular endothelium in the lungs, leading to leaky lungs. And histologically, if you do a biopsy, these patients will often have cryptogenic organizing pneumonia on biopsy. And the treatment is basically high-dose corticosteroids, and that will sort of be a theme for all the pulmonary complications I'll show you in the next few minutes. This is a patient that had pulmonary engraftment syndrome, who on day 10 started to become hypoxic. The neutrophil count had gone from 0 to about 110 at that point. The following 2 days later, the ANC was now up over 1,400. The SATs had decreased to 88% on room air. A BAL was negative. The patient was started on Solumedrol, mg per kilo, and within 24 hours had dramatic improvement in pulmonary symptoms, resolution of hypoxia, and was discharged about a week later and did well. So one of the hallmarks of this process is it comes on fast and it goes away very quickly with treatment with corticosteroids. Diffuse alveolar hemorrhage is defined as idiopathic pulmonary hemorrhage that occurs after the conditioning regimen to about 6 months post-transplant. The symptoms typically are dyspnea on exertion, hypoxia. Often we'll see a rising LDH and bilateral pulmonary infiltrates. Very rarely do these patients actually present with hemoptysis. And this condition is associated with a very high mortality in the range of 50% or higher. The diagnosis is basically confirmed by bronchoscopy. This is a diagnosis of exclusion, so importantly we need to rule out opportunistic infections as the cause of diffuse alveolar hemorrhage, particularly invasive fungal infections such as Aspergillus. Importantly, cytology will often, in almost all cases, reveal macrophages that are laden with hemosiderin as evidence for alveolar bleeding. This is the typical cytology that you'll see in a patient with DAH. So you can see macrophages are full of hemosiderin. And the treatment, as with the other conditions, is high-dose corticosteroids, usually 2 to 10 milligrams per kilogram of Solumedrol. And more recently, there's been the use of recombinant factor 7A or Nova-7. That's usually given as one dose and then repeated at 4 hours and thereafter if bleeding recurs. There are no controlled trials to establish the efficacy of Nova-7 in the context of this disease. But at the NIH, we had about a 50% mortality before we started using Nova-7 in combination with corticosteroids. and we've had a dramatic decrease in mortality. The vast majority of our patients with DAH now we can pull through with Novoceb and corticosteroids. This is a patient that had really super severe diffuse alveolar hemorrhage, a pediatric patient that had aplastic anemia that underwent an allotransplant, that had multiple episodes of recurrent pulmonary hemorrhage that was initially treated with steroids alone and then subsequently received steroids and recombinant factor 7A. And this shows a dramatic improvement in his chest X-ray 4 days after being treated with that agent. Moving along, idiopathic pneumonia syndrome is defined as idiopathic non-infectious pulmonary injury occurring from the time of engraftment to about 120 days post-transplant. The incidence of IPS is variable from institution to institution. Roughly 14% of patients will develop this complication. It has a very high historical mortality in the range of 65 to 75%, with median survivals of only 2 weeks. TNF-alpha is thought to play a major role as an inflammatory cytokine mediating this complication. The thought is that IPS may represent the consequence of alloreactive T cells targeting minor antigens that are expressed on pulmonary endothelial cells, so in essence a manifestation of acute graft versus host disease in the lungs. That's based on animal data. The treatment, again, is steroids, typically 2 mg per kilo of solumedrol given for at least a week. More recently, with data that TNF is a player in this disease, and that was based on work done showing TNF levels were elevated in the BALs in patients with IPS. Agents that block TNF have been used. In Etanercept, which is soluble tumor necrosis factor receptor that's FDA approved for treatment in rheumatoid arthritis, has shown some promising results in a recent study by Ken Cook, who was at Michigan. Patients were treated with Etanercept for 4 weeks, and this was retrospective data showing survival at day 28 in recipients of Etanercept was higher compared to their historical controls, 73% versus 33%. That use this agent, with also an improvement in median survival compared to their historical controls. So we'll move to the next question. A 55-year-old male, CMV seropositive with AML, undergoes an allogeneic peripheral blood stem cell transplant from his HLA identical sibling, who is CMV seronegative, without complications, having full donor engraftment on post-transplant day 14. On day 60 post-transplant, the patient complains of increasing dyspnea and exertion and low-grade fevers and has a room air saturation of 88%. He denies sputum production, hemoptysis, orthopnea, or flu-like symptoms. Exams reveal bilateral rales without signs of heart failure. A chest X-ray is shown. Labs reveal a normal CBC, electrolytes, coags, and a normal BMP level with an LDH elevated to 320. Medications include prophylactic Bactrim, cyclosporin, voriconazole. Blood PCR for CMV is negative. A BAL is performed and is notable for scant bloody secretions and normal appearing airways. Gram stain and AFB stain are negative. Cultures are pending but fungal stains are negative. BAL cytology shown reveals no malignant cells or viral cytopathic changes and is negative for CMV by antibody staining. Cytology samples are negative for pneumocystis by antibody stain and silver stain, although a PCR for pneumocystis returns positive. You should, A, diagnose pneumocystis pneumonia, begin high-dose Bactrim therapy. B, diagnose diffuse alveolar hemorrhage, begin high-dose steroids. C, diagnose diffuse alveolar hemorrhage likely from pneumocystis, begin high-dose steroids and Bactrim therapy. D, diagnose pneumocystis pneumonia, begin high-dose steroids and high-dose Bactrim. E, diagnose allergic pulmonary aspergillosis, advise the patient to discontinue gardening until he is 5 years post-transplant. You can start the clock. Okay, the most popular answers were C and D. and we'll go through each of these. So A, diagnosed pneumocystis pneumonia, began high-dose Bactrim therapy. So the pneumocystis PCR is a red herring. In this context, you often will get false positives, particularly if that antibody stain is negative. And in this case, the reason you would think that this is probably not pneumocystis, besides the immunos being negative, is the fact that the patient is taking pneumocystis prophylaxis with Bactrim. And patients, when they're compliant with this agent, we just don't see pneumocystis at all. So you can pretty much scratch pneumocystis out. Diagnosed diffuse alveolar hemorrhage, began high-dose steroids. So this cytology is showing hemosiderin in macrophages, and that answer is correct. D, diagnosed diffuse alveolar hemorrhage from pneumocystis, began high-dose steroids. So that, again, pneumocystis is not correct, so you can scratch C and D off and diagnose allergic bronchopulmonary aspergillosis. That's not correct either. I'm not going to explain why. So we'll talk about the most common complication after allogeneic stem cell transplantation, which is acute graft versus host disease. This is the consequence of engrafting T cells from the donor that recognize antigens that are disparate, particularly minor antigens between the donor and the recipient. It occurs from the time of engraftment to 100 days post-transplant. Typically involves 3 organ systems, most commonly the skin, which can present as a whole-body rash that can look almost identical to a drug eruption or like sunburn. The grade of GVHD of the skin depends on the amount of surface area of skin involved. The GI tract is the second organ that's commonly involved. The grade depends on the amount of diarrhea, with typically gut GVHD involving the lower GI tract, the colon more than the upper GI tract. And it can also involve the liver, where it can present as an elevation in bilirubins, an alkaline phosphatase, and in some cases may present also with elevation in transaminases, and the grade of liver GVHD is dependent on the level of bilirubin elevation. Chronic graft versus host disease, by definition, occurs after day 100. It's also caused by engrafting allogeneic T cells. It can literally affect any organ system in the patient. So it's different than acute GVHD, which is just restricted to those 3 organ systems. And I've listed a number of organs that can be involved. So it can, again, involve the GI tract, the skin, and the liver, but it can also involve other organs, such as the lungs, where it can cause bronchiolitis obliterans or BOOP or COP. It can involve exocrine glands, and that can lead to sickle-like syndrome, ulcerations within the mouth, connective tissue, where it can lead to a fasciitis syndrome, where patients sometimes look almost like they have systemic sclerosis. This is examples of 2 patients that had acute GVHD of the skin. Very commonly, patients will present with erythema of the soles or the palms. And again, this type of a rash could also be caused by drugs or viral exanthem. So we typically will get a biopsy to confirm the diagnosis, where we'll look for dyskeratosis or apoptotic bodies of epithelial cells. GI tract graft versus host disease typically presents with abdominal pain and high-volume watery diarrhea. It's rarely bloody. Patients also can present with nausea, vomiting, dyspepsia, and postprandial discomfort, in some cases a gastroparesis. The pathophysiology is due to transplanted donor T cells targeting glandular epithelial cells. It can involve the entire GI tract, but as I said before, the colon is more commonly involved than the upper GI tract. The differential diagnosis is relatively limited in a patient that receives an allo transplant. Things that we need to exclude are drugs. We use drugs like magnesium replacement in patients that are on cyclosporin or tacrolimus, and that can cause diarrhea. Anti-nauseals such as metoclopropamide need to be considered if a patient is on this agent as a cause of diarrhea. CMV colitis is also a common cause of diarrhea post-transplant. So if a patient presents with diarrhea and has a blood PCR that's negative for CMV, that makes a diagnosis of CMV colitis much less likely, although not totally excluded. And then infectious causes, the most common infectious cause would be C. diff diarrhea. So we typically will get a C. diff toxin, and if that returns negative, entertain the diagnosis of GI graft versus host disease. The grade of GVHD is based on the volume of diarrhea. So patients that have low-grade diarrhea, less than 500 cc's a day, grade 1 diarrhea, are usually quite responsive to steroid therapy and have a very, very low risk of dying from gut GVHD. In contrast, patients that have either grade 3 or grade 4 GVHD with more than 1,000 cc's of diarrhea a day, or bloody diarrhea, or an ileus, are more likely to have morbidity and mortality associated with this complication. The diagnosis of gut GVHD is based on clinical criteria, so patients have to have evidence for an engrafted donor immune system. If they've rejected the transplant and they have diarrhea, it's not from GVHD. They have to have clinical symptoms, they have to have absence of another cause, and then importantly, we confirm this diagnosis with a biopsy, typically a flex sig or a colonoscopy, to look for classic histopathologic changes that would be consistent with this diagnosis. One thing that's important to keep in mind is that these colonoscopies in patients with gut GVHD are often very normal looking grossly, but when you get biopsies back, you can see classic histologic changes for this, this process. This is what you typically see in gut mucosa in a patient with GVHD. So we look at the glands and we look for these apoptotic bodies. With the exception of radiation chemotherapy, there's not a lot of things that will cause glandular apoptosis. So this is almost pathognomonic for gut GVHD, and this is what normal colonic glands look like. The treatment for gut GVHD is the prompt initiation of corticosteroids, typically methylpred given at 2 milligrams per kilogram per day. Patients that are not on calcineurin inhibitors are restarted if that's been stopped, so they go back on cyclosporin or tacrolimus. All the drugs are given IV because they can have significant problems with absorption, and survival depends on the grade of GVHD. So those patients that have very low GVHD grades with low volume diarrhea have excellent, almost 100% survivals, and patients with higher grade GVHD, grade 3 or 4, have survival in the range of about 50 to 70%. Importantly, the major cause of mortality in these patients is infection. So the drugs that we use to treat this complication are associated with compromise of neutrophil function, and the integrity of the GI system is also compromised, so you can have translocation of bacteria. It's very common for these patients to develop bacteremia. It's also very common for these patients to develop invasive fungal infections. And at the NIH, these patients are all treated with broad-spectrum antifungal therapy, typically in echinocandin or voriconazole as prophylaxis. Grade 3 to 4 GVHD that fails to respond to steroids, typically after 3 or more days of high-dose steroid therapy, is defined as steroid refractory graft versus host disease. This is really one of the most dreaded complications of allogeneic stem cell transplantation. It occurs in about 10 to 15% of transplant recipients, and it has a very high historical mortality, with studies up to about 5 years ago reporting mortality rates of 85% or higher. Death from infectious cause is the primary contributor to mortality in these patients. There are a number of agents recently that have been used to treat steroid refractory graft versus host disease. Many of these agents are monoclonal antibodies that are targeting pathways that are critical to T-cell function. At the NIH, we use a combination of infliximab, which is an anti-TNF antibody, given with teclistamab, which is an antibody to the alpha chain of the IL-2 receptor, anti-TAC. And this combined therapy given with fungal prophylaxis and bacterial prophylaxis has resulted in dramatic improvements in survival in our patients with steroid refractory GVHD, with mortality rates dropping from about 90% historically to less than 10%. So we've had some real big breakthroughs in managing this complication. And that leads us to our next question. So this is a 49-year-old patient with chronic myelogenous leukemia who undergoes a non-myeloablative peripheral blood stem cell transplant using reduced intensity conditioning with cyclophosphamide and fludarabine from an unrelated donor, a T-cell replete transplant. The patient develops 3 liters of diarrhea associated with crampy abdominal pain on day 19 post-transplant on a Friday evening. So a patient like this might end up coming to the ICU with hypotension related to the diarrhea. T-cell chimerism shows 100% donor engraftment. Stool studies are pending. A CMV PCR returns low positive, was negative 1 week prior. A FlexSig cannot be performed until Monday. You should, A, diagnose probable acute GI graft versus host disease, treat empirically with steroids until biopsy becomes available. B, diagnose probable acute GI graft versus host disease, hold off treatment until biopsy confirms GVHD. C, repeat CMV PCR in 1 week. If the PCR shows increasing CMV copy number, begin ganciclovir therapy. D, begin CMV therapy. If diarrhea volume does not decrease, perform a FlexSig to rule out GVHD. And E, perform, this is Dr. Masora's favorite answer, a 24-hour fecal fat collection. Okay, so answer A, diagnose GVHD, treat empirically with steroids, and D, begin CMV therapy if diarrhea does not decrease, perform a FlexSig, where the most popular answers. The correct answer is A, diagnose probable acute GVHD of the GI tract and begin empirics therapy with steroids. This is a very common presentation of a patient with acute gut GVHD. The things to keep in mind are the patient is certainly at risk for GVHD. They've received a T-cell replete transplant. The immune system from that donor is engrafted fully. And the patient has very high volume diarrhea. So typically with CMV, we see low volume diarrhea or crampy abdominal pain. You almost never see patients having more than a liter of diarrhea a day. So when you start seeing this high volume diarrhea, you really need to put GVHD very, very high on the differential. C. diff colitis typically will not present with very high volume diarrhea this acutely. Typically, we would manage these types of patients by getting a C. diff toxin back, and if it returns negative, we would try to get a biopsy, but if it was delayed, we would treat the patient immediately because there's glandular apoptosis occurring literally before your eyes. There's glandular destruction occurring, and if you delay treatment, you literally can denude the bowel in 2 to 3 days. So it's important that if you can't get the FlexSig immediately, that you begin empiric therapy. Importantly, if you start therapy, you can still establish the diagnosis 3 to 5 days afterwards. You'll still have histopathologic evidence for the diagnosis, so it doesn't confound making the diagnosis. The reason this is not CMV, a couple of reasons. One is that the PCR was negative, it turned positive. As I told you before, you usually have a 2 or 3 week lead time for CMV colitis. The stool volume is too high. And for that reason, and the other thing is you wouldn't guess that it's CMV and wait, and if they don't get better, treat GVHD, because again, you'd have destruction of the GI tract if it was caused by GVHD. Okay, so we're just about done. This is the final question. This is a bonus question. A 29-year-old male with AML, CMV seronegative, undergoes a T-cell depleted allogeneic transplant from an unrelated HLA identical donor. On post-transplant day 9, the patient develops fevers and a non-productive cough. His neutrophil count is 250 cells per microliter. A chest X-ray and urinalysis are unremarkable. He started on empiric ceftazidime for febrile neutropenia. On day 10, the patient remains febrile and becomes hypoxic and is noted to develop bilateral infiltrates by chest X-ray. His ANC has increased to 1,000 cells per microliter. His weight is stable, and his ins and outs are balanced. The BAL is unremarkable with a negative gram stain, negative fungal stain, with immunohistochemistry and PCR for both pneumocystis and CMV returning negative. Cytology on the BAL is unremarkable, and cultures on the BAL are negative at 24 hours. A blood PCR returns negative for CMV and low positive for HHV6. You should, A, initiate IVIG and foscarnet for possible CMV pneumonitis. B, initiate high-dose steroids and Nova-7 for probable diffuse alveolar hemorrhage. C, initiate high-dose steroids for possible pulmonary engraftment syndrome. D, proceed to open lung biopsy. E, initiate cidofovir for possible HHV6 pneumonia. Okay, so the most popular answer was C, initiate high-dose steroids for possible pulmonary engraftment syndrome, and that's correct. This is really a classic manifestation or presentation of pulmonary engraftment syndrome. The thing to consider here is that the symptoms are starting actually before the neutrophil count has gone over 500, and that's pretty classic as well. But these patients typically will have negative BALs. This patient is really not at risk for CMV because he's CMV seronegative, and as I showed you before, regardless of the donor sero status, CMV reactivation and CMV disease in these patients occurs extremely rarely, and the bronchoscopy certainly was not consistent with CMV. So this question was actually worth $25 deduction to your hotel bill. You can tell them Dr. Massour told you to take $25 off. But only if you got it right. So we're using the honor system.
Thanks very much, Rich.